Hey, the video you're about to see is our monthly mastermind call. And in this mastermind call, we're actually going to dive into trying to deliver your care plans and present your care plans to people to get much better conversion. So if you're having a hard time getting people to commit to those care plans, if you're getting a lot of, I want to think about it, or give me some time to take this home, or I have to go home and talk to my spouse, or I feel this is too expensive, and you're having really poor conversions, or people are just not buying into the care that you're trying to deliver, or perhaps you don't do care plans at all and you're still doing a pay per visit type of basis, this video is for you. You'll get tremendous value out of this. What we do is we talk about systems in place to try to build the urgency, making sure they're congruent with what you're trying to deliver, ways to present them, questions to ask, and concerns to deliver so that you can have much better success in getting people to commit to those care plans. Enjoy the video. I know you'll like it. This is good. So Brian and I were talking yesterday, and we thought today's mastermind call, we're going to go really focused on recommendations and finance. And this is part of the reason why. And what we like to do is we like to gauge our mastermind calls based on the concerns that the one-on-one coaching calls are bringing up. So where people are having challenges, people are having problems, especially if it becomes a common theme, these are good things to talk about. So this is really good one. And I'm going to say this is something that we coach on very, very regularly. Obviously, if you've got things congruently in your practice and your practice style is very congruent with your philosophy, that means day 1, day 2, your care plans, day 3, your wellness care is all very congruent based on what you're trying to deliver. And things just aren't falling into place as well as you'd like. And what happens is, if your recommendations in finance, if your care plans aren't congruent with the message that you're delivering, and people are getting to the time where you're presenting the care plan, and you're not getting, and I'm going to say at least 75% of your new patients to sign on to that care plan, then there becomes an incongruency. And here's what happens is that you start to compromise your core values. You start to compromise your principles. So if you're doing a corrective care program, then you start, accepting people on pay as they go, visit by visit plans, which is completely incongruent because they're paying more. They're obviously not going to follow through with your recommendations. They're going to quit. So these are things we have to talk about. So we're going to talk today a little bit about those care plans, the details of which, and all of the steps, the proper steps leading up to that care plan. So it's not a sticker shock when people get to the care plan and they go, whoa, I have to think about it. Oh, I don't know if I can do that. Oh, can I just pay as I go? And you're getting all these objections. So we're going to start talking about that. And I'm going to just say one thing before we get started here. And I want you to think about this. This is really good. And this is from the beginning of the coaching call that we had this morning. One of the people on the coaching call said, if you guys have heard the term, you can lead a horse to water, but you can't make him drink. Have you guys all heard that? Yeah. So a few people nodding, right? So you can lead a horse to water, but you can't make him drink. And the person that brought this up on the call said they actually said this to a rancher, and the rancher said, yeah, but you can make him thirsty. And I thought that's actually a brilliant perspective. So what they do, it's the same thing. They want to keep the horses hydrated. And if they bring the horse to water to the trough and the horse won't drink, they don't get hydrated. But if they give the horse a salt lick first and they lick the salt lick, that creates the thirst. And then they go over to the trough and they hydrate themselves. And I thought this is a brilliant analogy when it comes to chiropractic, is that we have to put the things in place so that by the time we get to that presentation of the care plan, the person wants care. They're ready to, they have their credit card in hand and say, whatever it takes, I'm in. Here it is. So these are the things that we have to start to talk about. So Brian, take it away.
Yeah, as we get into this, so I'm going to talk about, I guess, some of the setup that needs to be in DR. And if you guys have a lot of questions about that, then we should probably likely have an extra call just on DR. I know that's going to be part of our training when we get into October at our next DC2 seminar. From some of my previous conversations with Pat Ray, I know he's on here too. It'd be great. Pat does something a little bit different. I think that most people on this line that would be helpful. And some of the spins off of Corey's Marco to the group, where he talked about how he started changing the way he was delivering care plans based on the results he was getting. And so the framework around that, if you're not seeing the results, something has to change, right? And I would say, like, that number at your report, if you're not getting 70 to 80% of people on care plans, you got to look at tweaking some because something's not quite right. Something's not landing. Now the path Dr. Corey chose, I wouldn't say it necessarily is right for other people on the line. I wouldn't say that'd be the right first step from my perspective. I'd examine all these other things first, and Corey may have already examined those, which is why he ended up there. But the big piece of this, like the recommendations finance, like that plan conversation only works if you have built rapport first. That is through day one and day two, but there's a huge part in your report, and they have to be able to see the vision. And it has to be something that they want, not something you're trying to convince them into. So they're choosing care versus you trying to sell them or convince them around care. And like the other piece in that, and we'll talk about these pieces then here in a bit of the nuts and bolts piece. I want to have questions. I want to try and keep this pretty tight, about maybe 15 minutes of teaching piece. In that report, they have to be able to see your heart. If they don't see your heart and why this is not just the science as to why it works or why it's good, but the reason you're so committed to it. If they can't see your heart, like if they don't see that, they're gonna have a hard time trusting you, which then you're gonna have a hard time closing into a care plan that's good for them. So, and this is why I'm such a big proponent of a live report. Like there is different options around it. I find it hard to share the heart piece at a good level if there isn't something live. So pieces around this then. So pieces in your DR that are key to be able to get to a good, recommendation finance one-on-one after is in that report. You do got to put a bit on, I guess, explaining the different models of health. Now, there shouldn't be a lot of time. Like in my experience, people are not looking for more meds. They're not looking for more surgery. That used to be probably a 20-minute part of my report. Now I think I nail it in 3, right? So it's just what do the different models look like? Do explain the nervous system. And somewhere in here is where the reason you're a chiropractor should flow in. And there should be something that's called the financial anchor, which explains what this looks like if people don't get care. So an example of what that would look like in your big why, like for me, it's my brother. And my brother, when he got sick, took 8 months off of work, cost him about $80,000 in lost wages, versus if he had found the underlying cause, which we knew was already there. We didn't in hindsight, we knew it was there, I guess I could say, that would have cost whatever your care plan is to correct, right? So there's a contrast. So patients are already seeing that in their head, and it's just like if you were my brother and go back in time, which one do you choose? And they're all saying, well, I'm going to choose the cheaper one, like the 6,500 one, not the $80,000 one. So you're creating a contrast as to what is the true cost of sickness and disability based on your personal experience versus them just seeing a bill on a care plan. The other key piece then is as you're going through and explaining x-rays, you're explaining cases. My recommendation is when you're explaining x-rays, you make it as simple as possible. My default, and probably a lot of you on this line fall into, we got a lot of education, we got a lot of heady stuff living in here. We can't explain it at that level. We have to explain it as if we're explaining it to a teenager so it's understandable. Remember, the point of the report is putting people back in control of their health, like them in the driver's seat. So you got to make it simple. So when we explain x-rays, and every x-ray should be explained the same. So there's whatever questions you're going to ask going through their x-rays in the room should be how you explain x-rays in your report. And so they get to hear it, 2, 3, 4 times over any case you got to go through. So now in the report room, it becomes very easy. They've heard the question several times. When look at their x-rays, they understand what's going on, and it makes it real simple. So when we explain x-rays in my office, it's normal or abnormal shape. And so then if it's abnormal, which would be subluxation, is there going to be pressure or no pressure on the spinal cord of the nerves? If there's pressure, are you getting 100% life from your brain into your body or something less than? If it's less than, over time, are you building more health or disease on the inside? What's going to be the ultimate result in something like that? And someone's going to say organ shut down, death, or whatever. Something's shutting down early. And what's the intelligent thing to do? And everyone's going to say fix it. So if we've made subluxation, the cause, the solution, really, really simple. So when I go into every x-ray after that, after I explain the nerve system, it's like, okay, so here's a picture of so-and-so. So real quick, normal, abnormal shape. Abnormal. Is this I'll call by their name. And my first one's Devin. Is Devin getting 100% life from his brain to his body or something less than? They all say less than. So on the inside, is he building health or disease? Disease. And for him, it's showing up as, and I go into the case, whatever his symptom is that brought him in the door. So you make it really, really simple. When it gets to the rec and fi part, then, because you've explained this several times, this needs to, like, rec and fi now, and this is the switching gears, this needs to be a conversation with the patient. This is not you going back in and re-explaining, right? So you're going to ask a version of those questions. I typically don't like to show more than 2 x-rays. I find it's confusing to show more. I find people get overwhelmed. There's too much information. They can't digest it. They feel they need time. So I'm going to show wherever their primary complaint is, I'm going to show that x-ray first. If it's a neck problem, I may only show the neck x-ray. If they got a low back problem, I'm likely showing that first and then transition to the neck if there's anything there. But it's real simple. It might be like, hey, so Stephen, so we're going to look at, say Stephen comes in with a low back problem. Hey, Steve, so we're going to be looking at 2 different x-rays for you. The first one's the side picture of your lower back. I just reorientate them. So just like in the report, red line's normal, that's our template. Black line's you. As you know, Kerr's supposed to be 45. Yours is only 23. So obviously we got abnormal shape. Does that make sense? There's pressure on your spinal cord there. And Stephen's going to be like, we're in a conversation, right? Okay, so with that pressure, does that make sense why you're getting the back pain you're dealing with? And they're going to be like, yeah, it does. Do you have any questions about this? Nope. Our biggest concern, Steve, is if this doesn't get corrected, what do you think happens here? And he's going to tell me, oh, it's getting worse. That's leg pain's going to get bad. I have other issues. Absolutely.
No,
Is this
I'm
something you know you want to fix?
I'm happy to treat you. Yeah.
There, I just muted.
Okay, cool. And that is the simple conversation. That's all you need to talk about. And so then, depending on what you do as far as like a stress film, you do an advanced x-rays, whatever that is, you can show them a pre and post so you know what correction looks like. And then literally you pull out the plan. But it needs to be super simple. So they've heard those questions in my office. It's three different patient stories, 3 different pre and post x-rays. They've heard them before. They've now gone through it. They've been able to answer the questions for themselves. And they make the commitment. Yeah, I do want to correct that. I know what's going on. I know what happens if it doesn't go well. And this is also, if they have any questions, this is where concerns show up. And this is where I then transition into the plan. Any questions about that?
Before we get into this, I just want to build on a couple things. So Brian nailed a few things there, and I just want to say and address a few people on the line, because I know some of you don't take x-rays. You might maybe use a nerve scan or you use posture pictures or whatever the case is. It doesn't matter. At least you have an objective finding. You have a normal versus an abnormal. But you see how the conversation, and for some of you, you're not doing live doctor's reports. You're doing one-on-one report of findings. Same thing. Before the person sees the care plan is that you have to show a normal. You have to relate that normal to an abnormal of where they are and relate it to principle. An abnormal x-ray affects the nervous system. If you have a nervous system that is compromised by subluxation, by scoliosis, by abnormal alignment of the spine, the body's ability to heal is suppressed. It is compromised. There's no way that you can express your full life potential if your spine is in that shape, if your nerve scan looks like this, whatever, if your posture pictures look like this. There's no way you can express your full life potential. And then I'm going to say, take it a step further by saying, to get this corrected, right? Especially if there's x-ray, subluxated x-ray, kyphotic neck, degenerative changes, nerve scan that's all red, whatever that is, this can take 12 to 18 months. So, and I'm purposely, intentionally doing this can take 12 to 18 months to correct. This is very severe. And you're explaining this to the patient. So what am I doing? I'm setting the bar for them. So when I set the bar, it's almost like I'm giving them the shock before I give them the care plan. So that when I give them the care plan saying, okay, can you commit to the first 90 days? If I've already set the bar at 12 to 18 months to correct, can you commit to the first 90 days? It's kind of like, oh, well, that's easy. That's an easy step. But if I don't reposition this, if I don't position their problem into something that can be corrected over time, and it takes a long time to correct, and I give them a care plan for 90 days, and they're in their mind thinking, oh, this might take a week, a couple of weeks, whatever. Then all of a sudden it's like, whoa, I need to think about this. This is a shock to me. And that's guess why you're getting I want to think about it. Can I go home and, can I let you know? Can we just do pay as I go? That type of thing. So, but if you can pre-frame it and set the bar, then all of a sudden by the time you show them the rec and finance, it's like a no-brainer. It's, oh, I can do that.
So then after you go through that and they have commitment, yes, I want to fix this, then it's like, okay, so this is what your care plan is going to look like. And we talk about frequency of care first. We're still not going through the numbers. My personal opinion is that the dollars, they are just numbers. We'll figure that out. It's first, do they want the care? Can they commit to the work involved first? That's the most important piece. So it's step by step. They've seen their x-rays. They know what's going on. Now we're going to talk about the work involved. I will explain the care plan. We have a sheet that comes out. The most popular care plan in my office for someone starting care is 34 adjustments over 4.5 months. So we walk through, okay, so what this will look like for you, Stephen, it's going to be 3 times a week for the first 6 weeks, then it's twice for the next 4, and then once a week for the following 8. So it's a total of 34 visits over the next 18 weeks. That's 4.5 months. During that time, there is home-based exercise you're going to do every single day. Doesn't take a lot of time, but it's important they get done every single day. Could you commit to doing all of that work? And it's a yes or a no. If it's I have a concern with that, then you have a time objection you got to solve. My first step in that would, if there is a time objection, there's just no way I could get here 3 times a week, then I'm just going to change how that spreads out. Same number of adjustments, same amount of time, but we're doing twice a week for longer. We're not going to change the overall outcome. We'll hit the same finish line, just start different, right? This is also a lot of times where someone will be like, yeah, I can do that, but I'm worried about the money. Great, just acknowledge it. Be no problem. We'll figure out the money here next. But if money weren't an issue, could you commit to doing the work? And most people are like, yeah, I just got to figure out the budget. But don't worry, we will figure this out. We've got to modify the plan. We will. Right? So you get that commitment to the work, and then you show them the plan. I do show a plan in my group report. So they've seen the sheet before, so it makes it fast. So it's not like what's all the stuff on the sheet. They know how they're all laid out. They have got a framework as to around, rough dollars based on options. And then we walk through that and we pick an option. One thing I found doing a lot of calls is that most doctors are getting a commitment. Yes, I want to fix it. They are not getting a commitment to option 1, 2, or 3, or whatever many options you have on your thing, and you leave that for the staff to manage. I will tell you, the doctor needs to get the actual commitment, because you own the principle more than anything else. The way this is set up, like you are in the boat with them, explaining it, like it's you and them together against subluxation. If you get their commitment to care and they go to the front and they're like, talk to your CA, and they're like, I can't afford that down payment. You've now dropped them into an administrative conversation. It's no longer about the principle, no longer about the outcome, no longer about the vision that they wanted to have for their health. So I'm telling you, take the extra, whatever it is, 90 seconds, and you get the commitment. Team can take care of all the paperwork once the commitment's there. But if they have an objection around that, like, hey, I want to do that, but I can't afford $1,000 down. Okay, have a conversation around it. Figure out, again, you want to fix this? Okay, again, what's the step for that?
No, I just think this is good conversation. I want you guys just to kind of think about statistically, ask yourselves these questions. Is your care plan congruent with what you're trying to deliver? So, if it is corrective care, whatever that care plan is, how many visits is it? How long is it? Is it reasonable? Do you think that your staff members, given the right situation and the right explanation, you did the exam on them and they had severe subluxation patterns, would they sign up for this care plan? Like, is it reasonable for the majority of people in your community? And I know some of you are going to say, oh, in my community, people are impoverished. They don't have money, blah, blah, blah. Well, and let's just try to surpass all that and say that every person has money. They have the money for care as long as it's a priority. And if they don't have the money, they'll find the money. If it's a priority, they'll find the money. So we just have to, again, create the demand for the care plan and resonate. So rather than, and Corey said this on the Marco Polo the other day, and that's why I wanted to address it, rather than reduce your care plan or try to compromise your care on a daily basis, accept people as pay as they go. If that's not what you want, if that's not the practice you're trying to build, let's work on creating this demand and creating the concern and the urgency for people to say, yes, this is something that I want. And I'm willing to pay a reasonable fee for myself and for my family.
Anyone got objections that show up when it comes to care plan they'd like to try and solve?
Sure, I'll go with an objection that I'm getting recently a lot, actually, is I have no idea if I'll have a job in a month. So I don't want to commit to something. I'll rather pay per visit because honestly, I have no idea and I am having trouble just to pay for food.
So, I mean, if you're, I mean, so my answer to that, Justine, and I get it, because I mean, we lived in an area where we would get that as well, is I would say, okay, you know, I totally understand, and I empathize with what you're going through. However, if this problem in your spine and nervous system continues to decay, you know, given a few months, a year, whatever the case is, will you be able to work? Will you be able to support your family? You know, if you just ignore this. So can we work out a plan that you can do this and gain some corrections so that we know that your body is healing and functioning, so at least you can function the way you want to function? That would be my answer to that, and that's the only answer I have. You know, it's almost a negotiation of the concern and the priority.
Yeah. Unfortunately, like people are more, or it seems more unsure and don't want to commit to anything. Like there's an aversion to commitment long term, right? So it's and I'm not saying everybody, obviously it's the 80-20 rule, but how do you catch those 20?
So yeah, I would say the long-term stuff, that's why we've gone to 4.5 month plans more than 12-month plans. I noticed that switch after COVID. So we made a big change. But if someone's in that tight of a situation, and we had something similar just the other, I don't know, can't remember if it was this Monday or the Monday before. But that conversation is like, I can understand. Actually, a couple weeks ago, I know the guy now. He doesn't know if he's going to be in the country. He's from Mexico. He's like, I don't know if I'm going to be here. So I'm like, so the conversation is going to be then, okay, so if we were to look at this, what do you feel you could afford and commit to on a monthly basis? So I may not do a heavy front-loaded corrective plan. It might be more of what does this look like month to month, right? Because like our wellness plans, it's the same number month to month is what they're paying. So I'm like, I'd put them into something that they know they have, like there's a long track to this, and it might be over 6 to 12 months, but it is month to month, and the adjustments are once a week. So we're going to move in the right direction. This might, if that fits your budget, and that's what we're going to look at. And if it turns out that, hey, you are making a decision between getting an adjustment that day or giving your kids food, then we can, it's a month to month commitment. So we will work through you with this. Right. But again, pouring into them on a whatever the adjustment basis is, building them and their strength and their value to care. But they've still made the commitment that they're going to be here. But if they need an out, they got an out.
And let's be honest, I think it doesn't matter what we do, we're always going to have those few people that
Yeah.
are going to find some way of basically explaining they can't afford care. They can't do it no matter what you do, no matter how you compromise it. So, and that's okay. You know, that maybe they're not meant to be in your office. Maybe ultimately they're looking for something different, whatever that is. But if that becomes the norm, you know, and you talked about the 80-20 rule, and I think if you're getting 80% commitments, then that's fantastic. I honestly wouldn't change a thing. But if you're only getting 20% commitments and 80% of those people are compromising, then things have to change, right? And if I can share a short little story with you guys, this is actually, I think, brilliant. I did a podcast a couple days ago with Dr. Kevin Jackson. And for those of you who don't know Dr. Kevin Jackson, he's been in practice for about 35 years in Pennsylvania. He's married to Dr. Selena Sigafus, who was the president of the ICA for a long time and happens to be the daughter. So Kevin's the son-in-law of Jim Sigafus, who I'm sure most of you all know. You know, he's a legend in chiropractic and one of the greatest orators and speakers ever in our profession. If you haven't heard Jim Sigafus, look him up on YouTube and he'll blow your mind. So they were influenced highly by Jim Sigafus. But this is really interesting, is that here is the education system that they have in their office, is that everybody that comes in has their day one. Their day two, before they get their adjustment on day two, they sit through an orientation. And the orientation, so in other words, their doctor's report, their orientation is 15 to 20 minutes long. Dr. Selena does it 6 days a week. So they have 6 doctor's reports a week. They maximize it to 3 people per orientation. So they have room for 18 people a week. And those people come to the orientation and they're taught the philosophy of chiropractic. It's not about necessarily x-rays and x-ray correction. They're taught the principle of chiropractic, and then they're given the option to start care. They have packages of buying pre-adjustment, but they accept people as they go because, and he said in his words, we want to create an office that people want to be at. I don't want to try to force people into care, talk them into care, convince them into care. We're trying to paint a picture of something that they want. And he went on to talk about a couple of stories and testimonials of people who have chosen their office opposed to medical care for their conditions. And they see over 1,000 a week and have for years. And so I thought that's so brilliant in the fact that they're putting their focus on educating people about what they do first and then giving people the choice of whether they want to be there. So I'm going to say that if you're having trouble getting people to sign on to care, if that's becoming a problem or you're compromising your care plans for that reason, then the education before that needs to be improved. And ultimately your results will start to change too. So I just thought that was a really brilliant story. And I'll let you know when that podcast is out because it was an incredible conversation.
Before I ask Pat to jump in here, I do have a hard stop at 11:45. You guys can keep going if it's still going. But does anyone else get objections? Like big ones are a time objection, a money objection, I got to go home and think about it objection. They'd like to try and solve. So again, this is happening. Like you don't have a close rate of people getting on plans that's at least 70 to 80%. So if it's lower than that, like what's that big objection that you get?
Beyond those three, you mean? I don't have any.
Yeah, no, I know you share. You do. You got anything, Stephen, or?
I get, yeah, some of those as well too. I also get like people, well, I'm going to be on vacation for 3 months or something like that, like a lot of Indian and Filipino patients. So then they're like, well, maybe I'll do it when I get back. Because I find, I don't know what it is, but I find a lot of people, they're like, I'm leaving next week. It's like, oh, crap. So, I mean, there's not too much that can be done for that other than try to follow up when they're back. But, you know, we're still not, like, we've definitely improved a lot of our conversion percentage, but we're still not at 70-80% yet. So, yeah.
What would you say is the most common 1 or 2 objections you get that you'd like to try and get better at?
I get, once I show them the care plan, can you print that off for me so I can take it home and discuss it or think about it or whatnot? So, I mean, obviously getting the spouse there is a big one. We've been working on that, but it doesn't happen every time. And then, yeah, just people like, I just want to think about it.
So 2 things, I just had this on a call with Blaine as well. So those 2, like preventing those objections coming up happens on day 2. And we covered this on our day 2 call that we did. So I'd really anchor back into that. Number 1, and Colin went through this, but when you're DR, it's like, this is the appointment that most people, if they're married, ask if their spouse can come along. Doing this for how many years been in practice, I recommend it because we just find people who, you know, have the support of the people that they kind of lean on, get better results. And so you then just confirm. So we have both you and your spouse, whatever that is, partner, set for this time. Does that work? Or do you need a doctor's note so it does work? And so you get it out there right away. If there's an issue why they don't think their spouse can come, then you just say, so in that report, we are going to be going through your x-rays, what you need for care and setting up a care plan. So we are having both time and financial decisions are being made in that. Is that something that you can make yourself or something you'd want your spouse involved in to make the best decision? You're just pre-framing it all, right? You're setting them up for success, right? Because the last thing I want is someone to come in, hear the principle, hear the message. They want this for themselves. And then they go home with a care plan. They're showing their spouse a bill. They're on fire. They want something. They show their spouse a bill. Those are 2 different, totally different contexts. And it's not going to work out well. It likely creates a rift, right? In the relationship structure, right? Regardless of care in your office, right? Because some person wants this because they have an idea. The other person sees a bill. No one wants a bill. So I'd say that gets set there. The other one is just make sure it's a blunt statement on your day 2 that at this appointment, we will be walking through what care looks like and setting up your care plan. Right? If you still then get the objection, I want to go home and look at it, say, absolutely. what's the piece you're trying to figure out? Is it the frequency? Is it the budget? What's your major question? The biggest thing I learned from Charlie Majors is you can't buy into their objection. You just got to ask them. You're there to coach them and lead them. So find out what that is. Some people, there's a money thing they don't want to tell you. But if you ask a second time, there's like, it's the money. Okay, let's have a conversation around that. Because most of them will still get solved in that room. They got a number that they think they can afford, but they're not willing to voice it the first time, or they feel they're not sure if it's a safe environment, etc. So I would work on those pieces, stronger day 2, and stay in the boat with them on day 3. Don't buy their objection. Just ask. You're there to help them. Pat, could you go through? So Pat and I had a conversation. We were at a board meeting in Nashville. So Pat does something a bit more unique, and it works very well in his practice. So just as a different view of this, and Pat's very successful with this. So I wanted to give people just another option with this. So Pat goes in, and correct me if I'm wrong here, but does a DR, but in the Rec and Fi, he offers more than one option that the person gets to choose from, a high option versus lower options. Could you kind of go through and give that kind of high level piece, Pat?
Yeah. The key element on everything is creating that value, as you guys have talked about. Urgency, value, all those things have to be done before you start presenting. So everything you talked about is absolutely true. So there's nothing really to add to it. Now, we go through the x-ray, we go through what the recommendations are, and then I use it's from Perfect Patient, I think, Bill Esteb's thing. It's called the Road to Recovery chart. And after I'm done, and my plans are not 3, 4, 5 months, whatever. Mine are 1-year plans. The majority are 1 time a week for 40 weeks. And the reason it works is because you can spread the money out, because that makes it more affordable for everybody. Because if you don't spread it out, it's going to be it'll be a ridiculous amount of money for them to pay. Because in our plans, we have for the top-notch plan, and again, this is all laid out in doctor report. We have the chiropractic correction. We have all the home care included, first round of lifetime supplements, metabolic programs included in that. We've got stem cells, platelet injections, regenerative shockwave, and decompression. That would be a top-level plan that we present to a case. Now, prior to going into the meeting, of course, we have a meeting with the team, and we sit down and we look at the x-rays and decide what our premium plan is going to be. It's not always the same for every single person. So I pull out the Road to Recovery, which says, it shows a riff from suffering all the way up to well care. And I'll tell them, I said, now let's go, we finished. Do you have any questions about this plan? No. And I say, okay, now what I've done, the plan I just presented to you is the plan I think is the best plan, the one I think is your best plan. Now, sometimes the plan I recommend doesn't match what your budget is, and it doesn't match your checking account. I understand that. So I built a secondary plan, and I take my pen on this Road to Recovery, and I have it going straight up in 1 year. Then I said, now for some people that doesn't match. So I built a secondary plan, which is going to take us longer to get you better, but it's going to make the plan a little more affordable for you. And if we need to, we will definitely, we'll polish our pencil if we have to, but the plan I will not accept is a plan where you're not going up. I'm not going to give you care. We'll part friends before I put you on a plan that's not going to get you better. But if we don't do anything, I'll take my pen and make it go straight down. What's going to happen if we don't take action? And I said, and they'll say it's going to get worse. And that makes it more expensive or less expensive, more expensive. So we're going to get a plan put together today. We're going to work something. We're going to get the details figured out. And I show them a plan, and I open it up, and there's 3 different levels. On the first one, the payment, the program is about $14,000. Okay. The payment is $1,205 a month. Okay. And I look at that, and there's 4 options. They could do quarterly payments, down payment, monthly, or prepay. And I get about 10% of the people agree to that one. It's not going to be huge, but you're presenting the best plan for that patient. Now, again, this doesn't happen all the time, but last week we got a family paid $27,000 up front. And this Friday, we got a lady paid $14,000 up front. So, I mean, it doesn't happen every time like that, I'm telling you. And so that's kind of the strategy. Now, again, if you're doing things like stem cell, shockwave, and all those things, that's going to cost you money. So we don't actually perform those procedures until there's money in the coffer to cover the expenses. That's just smart business. Okay. So we work through and I show them that plan and I look at their reaction and sometimes people are embarrassed. They don't want to say or whatever, but I'll look at them and go, all right, now, does that work for you? And they'll say, well, yeah, it works. I had to go move some money around. Okay. That tells me right there, they can't afford it. Okay. They always leave and don't come back with that kind of a strategy. So I said, let's go ahead and take a look at the secondary plan. Or they'll just outright say, hey, that's way outside. That's more, that's a car payment, or that's more than a car payment. That's my mortgage payment, whatever they say. And I said, let's look at the secondary plan. And so then I back it down to the secondary plan, somewhere in the ballpark of $500-600 a month. And what's funny is when I was doing plans at $350 a month, we'd always have to negotiate down to a $200 a month plan. When I show them a $1,200 a month plan, they agree to a $600 a month plan without any question. It's crazy town. A long time ago, Greg he said, you know, we teach this principle that's so much better than the medical model. It's so much better, so much better, so much better. And they're used to seeing a plan from a medical provider in hundreds of thousands of dollars. Then you show them a plan for $3,500. They say, so if this is so good, why is it so cheap? And so if you create the value, they're willing to pay the money. And they're looking at okay, what you presented is a $1,200 a month program. That makes sense to my brain. But if I'm showing them a $178 a month program, it's like, well, there's a disconnect here with the value. And so then they give me a poo-poo on the second one. Now, something that's interesting, I don't know if you guys do this or not, but when I show them the monthly plan, they always say no. And if I turn it into a quarterly payment, or sorry, into a payment every 2 weeks, they agree to it. So I'd say a third to half of the time. It's the same amount of money, but they still do it. It's insane. But I always do that before I move on to my next layer. I always show them that every 2 weeks. Even if they say it doesn't work for them, they'll agree to it. And then the final one, and before I go to the final one, I always say, okay, an attorney friend taught me this. And I flip over a piece of paper and say, okay, here's what we know right now, is that you can't afford $600 a month. I get that. But let's look at if I could put a plan together that was around $200, it would still be a correction plan. It's going to take us a while to get you better. Does that work for you? They say yes to that. I know my next plan is going to work for them, my final plan. Then I go and I split it and say, okay, can you do 300 or 350? That's a little out of my budget. Okay, let's split the difference again, 250, until finally we agreed. Last night I agreed to a number, it was 375 a month. Then on my spreadsheet, I plug in that number. It tells me what I get the number down to. I go into my program and I strip it down until it hits 375 a month. And then we agree to that. Now, if they just absolutely out of their budget, I'm that person who's, you know, a hand to foot. I mean, food, groceries, that's where I'm at. I'll show them it's a 46 visit plan over the course of a year. It's $187 a month. They get what's called a mini kit, which is a correction kit, because we're going to do corrective work no matter what. And 46 visits. They start off at 2 times a week, go to 1 time a week, and finish off every other. And in a year, we take our final x-ray and say, okay, now we're going to build a bridge. Then the next plan, and the next plan, and the next plan until we get them into the correction state. So that's what I do. If questions on that.
Pat, that's brilliant. And that's exactly what we're talking about. I think, you know, you just set the stage for everybody on the line here, is that if your plan, your go-to plan is, let's just say it's $400 a month or whatever that price may be, and we've talked about this before, is develop a high ticket plan and present the high ticket plan first, because then you set the bar. And so this is brilliant. You set the bar in that person's mind, and then when you present them your normal plan, which is $400 a month, it is easy. All you've done is you've just changed their paradigm. You've changed their thinking and opened the door for them to be acceptable to something a little bit different.
And the big thing there, like, Pat stays in the boat with them. He's just in there with them to figure out, how do we get you moving in the right direction, because it's worth it.
You have to start getting comfortable talking about money. There has to be fair exchange between doctor and patient. You can't pass this off to a staff member. It's not the same. Pat, great job.
And an important piece also, I'll just jump in, is it's not a negotiation. You're not, okay, can you do this? Can you do this? Can you do this? It feels like a car dealership kind of feel. It's like, how can we work within your parameters? I'm here helping you. I'm your friend trying to work through your budget so we can get a plan that will work for you. And going back to Justine, sometimes there just isn't a plan that's going to work for you, because you are that person. And we used to put them on a maintenance plan like Fitz you were talking about, but 90% of the time they quit. And it's just heartbreaking to me. And I just tell them, I say, listen, what we're going to do is we're going to go ahead and pass for right now. You're always a patient here. And when your situation gets better, just come back. We're here for you. We're always your doctor's office. We're here to help you. And they leave happy and they send referrals.
Awesome. Great job. Thank you for that.
Where are you located?
Me, I'm in Colorado and I'm in a very low income area.
And you said 14,000 just to, that was
Yeah.
one of the treatment plans?
Yeah, it's a $14,000 per care plan.
Wow. Okay.
Yeah, and that makes your anus pucker, doesn't it? used to make mine pucker too. And now it's like, it just is what it is. It's valuable and it's worth $14,000. And if you present it as valuable, if you're going, oh gosh, it's $14,000. I know you're poor and you don't have the money. Oh my gosh, let's negotiate. And you'd end up negotiating yourself down. I had associates used to do that. They're like, I can't afford this, so let's do the slower plan. It's like, how come you can never get the plan? Because they can't afford it. And so it's all about value in your heart when you're presenting it. Did you do an adequate job on your day one, your day two, your doctor report? And then in your breakout session, showing them this is going to get you better. Ignoring it's going to make it worse. And it's your deal. Okay. I'm here to help. I'm here to coach you through this. I'm going to show you, I'm going to give you what my heart tells me is your best program. And this is what I think is your best program. Now I get if you can't afford it, but let's build something you can work with.
I think too, Pat, if I could jump in and just chat from a Canadian perspective, as Canadians, we don't understand how we're paying for our healthcare because we don't actually pay for it, but it does come out in our taxes, about 50 to 60% of our taxes. And so I think I was just thinking about this, how can I create that value versus, the medical model, right? Because in the US, they're used to paying hundreds of thousands of dollars for their care. In the medical model is to actually in the doctor's report, talk about how much the average Canadian pays in taxes and how much of that goes towards healthcare, so that we are creating that value, so that they understand that, if it's a $14,000 care plan, this is not that much. It's going to save the taxpayers, $28,000 or something like that, right? Because you are stepping outside of that model.
All right. Good call. Good perspective. The other thing I'd say is just go back and look at, are you getting the conversion? Are people getting on to care? Are they on care plans? And if they're not, you got to go back and relook at this. What's happening day one? What's happening day two? What's your commitment to really getting people better versus, like I said, accepting their objection, not staying in the boat with them, again, just going with what's easy versus trying to be a difference maker in your community.